until I retired in 2018, I practiced as a public health doctor for the National Health Service, and I was also an academic. I was senior lecturer, then professor of epidemiology and public health in Newcastle, and then I held the chair of public health in the University of Edinburgh until 2018. Subsequently, I've been emeritus professor of public health. Now, currently, I think we've gone wrong by actually allowing the infection to happen in very high-risk groups, like the elderly. In Scotland, about half of the deaths have occurred in care homes for the elderly. It does have problems in the young, and occasionally it will cause a death. And we've described the Kawasaki-like syndrome. But these are very rare occurrences in people under 25. And even in people 25 to 35, especially women, serious side effects and deaths are extremely rare. My argument is we lift some of these restrictions on the younger populations. We're not forcing anyone. We inform people about the risks and benefits of doing. We also teach young people how they should be behaving when they come into contact with older people. I would like young people to be behaving very responsibly if they meet me. I don't want them coming up to me and giving me a big hug or shaking my hand or trying to shake my hand. I want them to keep their 3 feet away, or even better, 6 feet away. So we have to, it would be a different dialogue with young people if we go down this route. At the same time, we inform older people and those at risk. So some young people themselves are at risk. They have immune disorders, or they've got type 1 diabetes. They need a different dialogue to protect them. And I've written in my paper that while schools are now opening, there will be some children who should not go to school, the ones that are very high risk. If we only had one child in every 30 who needed homeschooling, we can provide the facilities for that. One thing that's been very interesting is that quite a few people who are not doctors, not public health people, just general members of the public have read it, and I find a lot of support for it. One of the main purposes of me writing this paper is to open up a debate. I think the public have not had any input into the debate at all. It's been very top-down. It's been controlled by very senior public health people and by politicians. And we're in a very difficult situation. There's no doubt about it. We can't get away from it. And what the right actions are is not at all clear. You know, people say we're following the science, but there's no direction in science. You know, science doesn't work through direction. It works through disagreement. And scientists will necessarily disagree with each other. That's why we have politics. Politics works through a democratic process. You take a vote, 6-5, therefore that decision is taken. Science doesn't work that way at all. Indeed, science works better when there's a lot of disagreement and people are willing to think through the disagreements and do some research or scholarship to try and resolve the disagreements. So we shouldn't be looking for a consensus from scientists and science. If I can turn to so I would like the public to be involved far more. And the public has been involved with my paper. Even before submitting it, I had about 6 people who are not doctors, just ordinary members of the public, read it. And by and large, they told me they liked what I said, and it was very sensible. And since then, I've had a huge amount of feedback from people, strangers just writing to me out of the blue. And I would say 95% of everyone that's contacted me has been positive about this paper. It's time for someone to speak sense. And I'm not a Twitter user, but I did look at some of the tweets, and I would say 95% of the tweets around this paper are positive. It does raise antibodies in some people, and of course, that's the whole point of writing the paper. If no one ever objects to anything you ever write, you might as well not have written it in the first place. You've not made any advance. So, but at the moment, I would say the public mood and the mood amongst many public health people and scientists is it is time for a different kind of debate, a more open debate. I'm not really an authoritarian person. I don't like people telling me to do this, that, or the other, and I will get fined or jailed or whatever if I don't do it. I would like people to inform me, and then I can weigh up the risks and benefits for myself. And I believe the public is reasonably intelligent and they're able to weigh up the risks and benefits for themselves. And I think I'm a great believer in statistics. I'm an epidemiologist, and actually getting the statistics out and portraying them in the right way, in a way that people can understand. And I think I've done that in relation to children, with working with my son and another colleague. And we've now got this new paper which sets out the statistics, as I've already explained to you. And when you actually show people the statistics, they can actually learn from them. Whereas if we just keep on telling them things without showing the statistics, I'm not sure what people are supposed to do. And so I would like to see the politicians and public health people actually giving the numbers. Let's see the numbers. And it's not the number of deaths that matters, it's the number of deaths per million.
That daily trickle of deaths coming in is insidious, because people in Scotland, to your point, vastly overestimated when polled the number of deaths that took place in the UK. And that speaks to something wrong with the science communication that I think you're highlighting in terms of people's passivity towards some of the public health measures that I think they know they don't want implemented on them, like on them as a political intervention into society. And I guess where you might get some of this pushback is that now some cringe at the idea of lockdown because it sounds like, once again, society won't be mobilized against the virus where it's actually needed in favor of these kind of strict but negative theatrical interventions from political authorities. I mean, we can look to Australia and see these limits on outdoor activity, things like that don't really relate to the dynamics of the virus. In Australia, the media has gotten to the point where you had these two teenage girls who traveled within regions within the country, and a Murdoch-owned paper basically docked them, plastered their faces in the media, and the headline was "Enemies of the State." And so, at the same time, others who might actually agree we're not doing enough for high-risk groups, when they hear no lockdown, they're kind of baffled. Well, look at how little we're doing, though. And so these politically charged terms ultimately distract from these key questions clinically, and they distract from, well, if you're experiencing community resistance, when I would cover Ebola in the past, for example, there was no question that we had to have a conversation about how public health interventions stoke community resistance unintentionally. That was a given, that needed to be understood, adjusted for, learned from. Now, that doesn't seem to be a conversation in this pandemic. It seems like things are so close to home that there's that culture war. There's that feeling of there's no redeeming society. They're not going to listen to any reasonable precautions and things of that nature. But when you look at some of the violence that has erupted from things like mask mandates, those are social tensions that, one, are already very heightened by the lockdown response, and two, they're social tensions that it doesn't actually help workers in these restaurants and things that were now every time somebody's rude to a restaurant worker, it's a news story, which if we did that during the full opening of business, and we'd have a news story about that daily. We're not actually protecting any of these workers by creating these situations where fringe people are going to resort to conflict. It seems, if anything, the social chaos that's been wrought is far more responsible for the violence than broadly the public speaking.
Well, if I can turn to one or two things there, I think I've said, published this in the BMJ as a letter. The data need to be presented in a much better way. We can and must do better. Published in the BMJ. I'll send you some stuff later. But really, the critical thing when a disease varies so much by age and sex. The critical thing is to produce all the data in 10-year age bands. Testing data, who's positive, who's negative, and we should also have the data by male and female, because the big difference is in the middle-aged males have got more than twice the risk of death as women. That's not true in children. It's not true in the very over 80s either. So we should be presenting the data by male and female and in 10-year age groups, whatever the data, so we can actually begin to interpret it properly in an epidemiological public health way, and people can then make more rational decisions. The second thing is the media also have a role in perhaps highlighting how many people have recovered from this. And I think they do have. Currently, we are a little bit focused on the most severe outcomes. Now, people want a completely risk-free society. People want zero COVID risk. We never had a risk-free society in the whole history of humanity. We never will have one. There will always be risks. Currently, we're running a lot of risks from people who are not getting their cancer diagnoses and not getting their cancer treatments, from people who are not going to have their chest pains examined, from children who are not being immunized, from parents who are not going to work and they don't have any money and their children are starving. The costs of the interventions against this virus are going to be far greater than the costs of the virus itself, especially in low and middle income countries where people are on a daily wage. The risk of starvation, diseases related to starvation, the diseases related to failure to immunize children to other diseases, these risks are vast. And I mean, I have calculated in my paper that even if everyone in the world was allowed to get this, the maximum number of deaths would be 30 million. I think probably that's a way overestimate, probably truly 15 million or so. But we could easily see those kind of deaths from the consequences of lockdowns in the world. And so we have to see this in perspective. And we're not going to get 15 to 13 million deaths because we have started to do sensible things like social distancing. These are not difficult. Well, they are difficult in low and middle income countries, but even there, it is possible to say to people, don't touch each other if you're not husband and wife, or if you're not in a partnership, don't touch. It's we have different forms of greeting. We don't shake each other's hand, etc. So we have to do all these sensible things. I'm a great proponent for all these sensible public health measures, but I'm also a great proponent of keeping things in perspective, and we have to add a discussion of what I'm calling population immunity into our entire strategy, public health strategy for managing this pandemic. That's all I'm saying. I'm not forcing anyone to go and get the infection, not at all. In fact, people have spoken about how young people should be asked to volunteer to be exposed to the virus so we can test out the vaccine quicker. And Nobel laureates have got together to make that proposal. That just indicates that in young people, this is still a relatively mild disease. That doesn't mean to say they won't get sick. They will get sick. Some people will get sick. It'll be like a flu-like illness. Some of my friends' children have had it, but they will shrug it off, and they will get partial immunity. People say, well, we don't know anything about immunity. Of course we do. We know what viruses behave like. Whether it's going to be a lifelong immunity or not, we don't know. Probably not. But the immunity will last for this season. Until this virus mutates and changes a little bit, we will have, if you're infected once, you will have immunity to this season's virus. To my knowledge, at this point, no one has ever had this illness in a clinical way proven and then had it a second time in a clinical way proven to date. But that will happen too. Rarely people do get the same infection twice. But when you get influenza or common cold, you don't tend to, the rest of your family gets the common cold. You don't get a second bout of the second cold, not that one. 3 months later on, you meet some other strangers and you get a different common cold. So that's the way virus infections work. We know about viruses and how they work. If people are looking for permanent, lifelong immunity from a single infection, they're asking for too much, because that's not the way viruses tend to behave. But if you're looking for immunity for this season to this virus, this strain, I think you will have it.
Well, to your point, also, some of the studies that try and find, based on seroprevalence or what have you, we're now seeing that we really don't even know per se if antibodies are the best way to test for immunity, if T-cell mediated immunity is the best way to do these surveys, for example. And that speaks to just how underdeveloped the scientific conversation on population level immunity is. Because you also look at, for example, to your earlier point about low and middle income countries where HIV, tuberculosis, malaria cause such a high health burden, they have a younger population.
Yes,
and so suddenly all of the international support for these issues that are really, really pressing there is disrupted. However, if you look at the infection fatality rate in recent preprints about Kenya, for example, very low, lower mortality than in the United States, in Belgium, Sweden, Spain, whatever country somebody wants to pick as their example. Now, if I lived in one of those countries, I would at very least be scratching my head, and not only at the deprioritization, but at public health advice that encourages me to not go outside, but instead to quarantine in multi-generational households that are often much smaller than households in other countries. So when we're looking at, and I know I've raised two different issues here, so it's one is, what are the ways of assessing immunity? What are the ways of assessing in the population? Do we even need to do tests? Can we look at the results for in a place like New York, for example, and say we'll figure out why later? Or do you have a suspicion of what that is? And then we'll move on to that other question.
All right, let's take some of these questions you've raised. On immunity, as I discuss in my paper, immunity against respiratory viruses is primarily cellular. It takes a while to develop your antibodies. They're not there. They have to be developed. The immune system has to develop them. If we didn't have some immunity, we'd be dead before the antibodies appeared. The virus is replicating very fast. Your phagocytes and your T cells and other cells are all working away to try and contain the infection you've been confronted with. For the most people, that system will solve the problem. For some people, that will not solve the problem, and the antibodies are then formed, and they help to resolve the problem. And the antibodies and the T cells are also, and the cellular system is also primed for a future infection. So that's part of your immune system. It's an incredibly important part of your immune system. Antibodies will be developed and then they wane. That's true for every infection. So your antibodies decline, and due course, when you re-encounter that pathogen, there's a memory in your immune system, and it can rapidly produce antibodies. Whereas in the first time you get it, it takes a while to produce the antibodies. Second time you get it, the antibodies are produced very fast because there's a memory on that particular, how to produce that particular antibody. Obviously, I'm not an immunologist, but I know enough to understand the principles. Now, the other thing we have to remember is all tests have false positives and false negatives. When a disease becomes very uncommon, most of the positives are false positives. We've published a paper called Test, Test, Test. It's in the journal Public Health. And we've set out 12 tables to indicate what is the likelihood of a test being positive. Even a test system that's 99% sensitive and 99% specific will produce a great many false positives in circumstances where the disease is rare. And we've set out the maths of it in that paper and discussed the concepts. So we have to worry when the disease has been controlled, we have to worry about using tests alone. Now, currently, it's probably estimated that somewhere between 5 and 20% of most populations currently across the world have got antibodies. Let's take the low number, 5%. Probably the truth is a bit higher than that. That is indicating that the disease is actually very widespread, far more widespread than the numbers of reported cases and the numbers of reported deaths. Now, you've mentioned infection fatality rates. So the question there is, if 100 people got the infection, how many would die? In the low and middle income countries like Ghana, I think you mentioned Ghana, it's probably about 1 in 1,000. In countries like the UK, it's probably closer to 1%, about 10 in 1,000. So it's going to vary greatly, and it's going to vary according to age primarily. Age is the key factor here. So I think I've already touched upon the fact that in countries like mine, the UK, many people are going to die from cancer prematurely because the hospitals are not providing cancer diagnoses and treatments at the moment. Many of them are not. In countries like Ghana or South Africa or India, Mexico, Peru, people are going to die from other things. Some of them you mentioned, the failure to get their treatments for HIV or whatever, failure to get immunization, the disruption of many things. And we have to start balancing these things. I've said in my paper that it's time for modeling the impact of the measures we're taking to control this pandemic. We need to set that impact alongside the impact of the virus itself. And money does matter because money is the basis of health. Wealth creates health, and health creates wealth. To say that we should only be worrying about health and not worry about wealth is just a false argument. We have to balance out both and try and maximize both. So wealth matters, and we can't allow our economies to just tumble.
Point. I mean, there has to be, to shut down production and mobilization of civil society is not necessarily what's going to lower case fatality rate in most places. I mean, you can have these initial several week kind of, how do we increase ICU capacity in countries that don't have a high pre-existing one, for example. But once you extend that months and months and months, it very quickly the adverse consequences become massively
massive. And we're all this sort of, we open up, then we shut down, we open up, then we shut down. It's not the right strategy in my view. You mentioned also indoor and outdoor spaces. Very few people are going to get this infection outdoors. So if it's at all possible for you, get outdoors, work outdoors. You mentioned multi-generational households and asking people to stay indoors in multi-generational households. I can't think of a worse public health approach than that. The place to wear masks is indoors. If you're in a multi-generational household, that's the place to wear masks. And that's the place to maintain, as far as you can, some social distance, whether even if it's only a foot or two, preferably at least 3 feet longer. Open the windows. If you can't get out, that's my advice to people is get outdoors. Open your windows. Open your doors. Let the fresh air in. The infective dose for this virus is not one virus particle. We're working on a paper. We have put up a preprint on this. It's very difficult to get an answer, but currently it's looking like probably several hundred virus particles have to be viable ones, have to be inhaled by a susceptible person. We're working on it. Many people are working on it. It's one of the most difficult things to answer, but it's not one. So let's not get obsessed with using all this. We might do a lot of harm to the environment through various disinfectants. In my view, disinfecting streets, I've seen some countries disinfecting the streets, the pavements and the roads. That's not where the virus is coming from. It's coming from close contact with people. And
sorry, finish your point.
And so it's people, and in those multi-generational households, the young people need to know how to behave when they come in and out of the house, and they come in and out and greet their elders. In my society, I'm an Indian, close contact is very important for maintaining socialization. But normally I would hug my children. All my children are grown up, but we all have a good hug when we meet each other, and I haven't seen them, but recently two of my sons and their partners have visited our house, and I have not touched them. And I've said to them, even within the house, we have a 3-foot rule in the house, preferably 6 feet, and when we're outdoors, 3 feet. It's not always possible, but we're trying to enforce it. And that's the kind of advice people need. Get out of the house if you can. If you can't get out of the house, especially if you're living in a household with your grandparents, you can speak to your grandparents from 6 feet away. And if you've got a cough, you wear a mask inside the house. That's where they're needed. But may I say something about masks? And that is, if the evidence was strong, it would be a lot better. The evidence is largely theoretical. I don't understand why people have not done the trials to produce what we normally consider to be good public health evidence. But anyway, they haven't. The trials that do exist seem to be around influenza from the past, where masks were not very effective. They may be effective here, or they may not be. But the way they're worn is certainly not effective. If you watch the media, look at different countries, and you see the masks are wafting around the place. They're slipping down from the nose. I've watched an interview with someone when the mask was put over the nose about 8 times in a minute. It slipped down from the nose 8 times, and the person was touching the mask and lifting it above the nose. And some people, they put it under their chins, then they're loose and wafting around. These kind of masks are not going to help. If we're going to do masks, they should be produced in the tens of billions by governments, and they should be effective masks that are going to work. This idea that you just let people do whatever they want, I think it will work, especially if you're coughing and sneezing or you're spluttering. I think they will be very helpful probably, but they have to be worn properly, and they have to be good masks. And perhaps it'd be better to provide them. After all, we provide so many other things. Why not we could manufacture masks by the billion and provide them to people, effective masks.